So you guys want to know what ICU nurses are like. ICU nurses are some of the most intelligent, intuitive individuals. It takes a high level person to really cooperate and be knowledgeable in a very drastic condition. So when a patient is crashing, that is a very hard place to be, and you need people who are very concrete. There's a lot of looking down on new grads because they're not that knowledgeable. There is a lot of maybe not helping. There's a lot of conversation of throwing your newborns to the wolves kind of mindset. That is a thing within critical care medicine. But what I want to say is that it's about your facility and the people that work there that offset those stereotypes. So for me, I went to a facility where it just wasn't in the greatest environment. I felt like I wasn't being supported by my team members, and my end goal was to go to CRNA school, and that idea and concept just was looked down upon because I was this new grad nurse who hadn't been there for long and already wanted to go to the next step. I eventually left that facility and went to another place. From the first day into now, I have been cared for, nurtured, and pushed by my team to become the best nurse that I can. And they furthered me into my desire to go to CRNA school. And they're really the biggest factor into why I got into school. When we talk about what's the ICU like, it's really what is your facility that you're choosing going to be like. Try to find somebody who maybe works there or knows about the hospital, and that's going to give you insight into what those people you're going to be working with are truly like. So what are ICU patients like? Truthfully, they're some of our favorites. They're sedated and ventilated. We as a care team are supporting their airway, we're supporting their other organ systems. So you might be using blood pressure medications to increase their blood pressure or decrease their blood pressure, depending on what goals you have. You're gonna have sedation medications and hypnotics to keep them calm and relaxed and to comply with the ventilator, because this machine is pushing air into them to help them breathe and facilitate the normal breathing pattern that we have now. Normally, if I stuck a tube down your throat and try to make you breathe with a machine, you're gonna be coughing and bucking a lot. Bucking is a word we use when somebody isn't complying with the ventilator. But using hypnotics and sedatives allows us to get them comfortable and relaxed. What else is the ICU like? Well, there's a bunch of different equipment, from a rapid infuser, which we use in really trauma cases and a lot of times in hypovolemic situations, and it rapidly transfuses blood and fluids into a patient. We have CRRT, or renal replacement therapy, and this is long-term renal replacement therapy. So this patient will be cannulated, and basically you'll be pulling blood for them, and this machine will filter their blood just as the kidneys would. You have, Foleys, which are pretty typical. You have OGs, you have NGs, so oral gastric or nasal gastric, and you can do tube feedings for nutrition, which is a very highly important thing in the ICU, because when they're sedated and ventilated, they can't eat. So it makes you wonder, how do you get the nutrition you need? Well, we give you tube feedings. We give you IV fluids if we need to. So there's a lot of thoughts and processes that go into the ICU and the care that you're going to be delivering. And there's even more equipment that you're going to be utilizing also. It's a great place to really be surprised every day you go in. Take it all in and embrace it. So let's talk about autonomy in the ICU. Truthfully, it's more about comparing autonomy into other portions of the hospital. When you're on the floor, so usually like a med-surg unit or a progressive care unit or intermediate floor, you are going to be limited in your autonomy. You're going to have to get an order for everything you do, which is the same case in the ICU, but it's a little bit different. We'll talk about that. On the floor, you have to contact a provider who typically is not around through a secure messaging, or you might have to call them to get a new order. Now in the ICU, our residents, fellows, or even our attendings at times are in our unit in-house. So this is really convenient because I can go see an issue with my patient or a change I would like to make, go talk to them real quickly, and then have that change made that fast. Whereas on the floor, you might have to wait 10, 30, maybe an hour to get one simple thing done. So the best thing with the ICU is the autonomy portion of it. And as you gain respect, experience, and knowledge, you'll have a lot more autonomy from your providers and from your coworkers. I mean, there's been times where I've been able to initiate intervention and talk to my provider afterwards, because he knows and I know about how we would manage a certain situation. I'm not giving any medications, I'm not doing anything like that, but I am preparing for things that he might or she might want in that situation. So if I notice my patient's blood pressure is being managed well, it's going up and down, I might be using a blood pressure medication to help manage that, and it's just going back and forth, I might start initiating a arterial line. So I might go get the bag for it, I might go get the equipment, and might start setting up and say, hey, we need an A line in here, could you come and do it? And they're gonna say, is everything set up? Is everything I need in there? Boom. And then you've already started the progression towards the next step. So it's really great. It saves a lot of time and it helps with patient care. That's the biggest thing. Autonomy helps us help the patient faster, more efficiently, and as a team. What is the bread and butter of the ICU? Typically where I worked, I was a generalized ICU. And typically what you're gonna see there is you're gonna be seeing patients who are coming in with respiratory symptoms. Let's say like a hypoxemic event. So let's say they're at home, they're having trouble breathing. So it could be a pulmonary embolism, it could be pneumonia, it could be a bunch of different things. And recently for the last 2 years, we were facing COVID. It just depends on where you're working. If you're in a surgical unit, you might be seeing a lot of, back surgeries. That could be your thing. If you're in a neurological unit, you're gonna be seeing a lot of strokes, hemorrhagic and ischemic. So honestly, it just depends on your environment. Now what I want to talk about is what equipment you're going to be seeing. A lot of things you're going to be learning, and what you should hone in on is a CVC, which is a central venous catheter. So that is usually put in through a large vessel, a vein. Usually it's going to be your IJ, or it's going to be your femoral vein. Now, that's going to be used to infuse things. You can use it to transduce pressures, so like CVP, you could use for that. And it's a great way to access directly into your system. Now, another thing we're going to use is called arterial line. Arterial lines, or A lines, are going to be placed in the radial artery. You can place them in the femoral artery, and you could also place them in the brachial or the ulnar, which are typically not seen. And what those do is those will give you a blood pressure, but it's second by second. The pressure from the bag that you place, and you fill it up and you squeeze it so that it is pushing against arterial blood pressure. And what the transducer does is that it reads off a second by second change between the both shifting back and forth, simply. So those are going to be the two main things that you're going to be seeing a lot of in terms of new monitoring devices or new types of catheters. When you're an ICU nurse and you are responding to a code situation, maybe a rapid response, it is going to be in a situation where when you get there, people are going to have their eyes on you. They're going to be looking towards you to help out. So before you go to a situation like that, make sure that you feel competent to help out in that type of atmosphere. Because once you walk in that door, all of that pressure is going to be put on you. During that time when you're there, make sure that you're helping out and not controlling or pushing people, because that does give a negative aspect to the ICU and even you as your own character. Be there to help out, be there to take charge when and as needed, but when it's over, be there to educate and help them and better ways to assess, prevent, and to manage a situation that has spiraled out of control, like a code or a rapid response. As you become more familiar with your hospital and your unit, you'll begin to build relationships among advanced providers. So that includes nurse practitioners, physician assistants, and physicians themselves, meaning residents, interns, fellows, and attendings. It's really important that you build a relationship of trust with them, because they're going to be looking at you to help manage that patient. A physician doesn't always know exactly how to do something, but they do know what needs to be done. And that's a very important thing that you need to understand too, is you need to start looking at it from their end. Why are we doing what we're doing? And how are we going to do that? Because if you understand that, that shows them that you are someone that they can trust and rely on. And not just talking about physicians, but also NPs and physician assistants. You will have their respect, and that'll help you get the things you need for your patients more quickly than if they didn't trust you. If they felt like they had to, back check everything you said. make sure that you're taking the time to be respectful, enjoyable, and, just a team player, because that's going to make all the difference for your patient's care and the relationships that you have in the hospital.